I started my career in the nuclear industry. And in the nuclear industry, when I was being trained as a human factors engineer, essentially we were in a similar situation that a lot of healthcare organisations are in now, in terms of not having human factors standards embedded as part of the design of the environments and the systems that we work in. And so what we used to get in our nuclear power plant control rooms was lots of controls and displays where the panels all looked the same, the controls weren't discriminatory. And we used to get nuclear power plant operators working in those control rooms who'd put little sticky notes with notes to their buddies. You know, function F1 relates to display panel that's at the back of your head on the right. And that's because they were trying to navigate their colleagues around a poorly designed environment. Now in the nuclear industry, we have human factors design standards for control rooms. You have to comply when you design a new nuclear power plant with those standards. And we've essentially designed out a lot of the fallibility and made those control rooms far more error tolerant than they were in the 70s and the early 80s. So when I came to work in the NHS, I started working in the NHS in 1995, observing teams of paediatric cardiac surgeons as they carried out the arterial switch operation. And for me, coming from the nuclear industry and going into an operating theatre was just sort of like looking at a human factors ergonomics nightmare. Because, you know, you work in an environment which really is designed for unreliability, with lots of alarms going off, panels, displays, that really don't consider ergonomics, don't consider how our brains are hardwired. So I've been working in the NHS and other industries as a human factors professional for over 25 years now. And I see the contrast in terms of design and our understanding of what human factors is in the NHS versus other domains. And I just want to start talking really by thinking about reliability of clinical systems and processes, because my key point here is that in the NHS we have this overarching culture of tolerating unreliable systems and processes. And what happens is good people, good clinicians, good healthcare teams go to work every day and they work around poorly designed clinical systems, poorly designed IT, and they make the service deliver in spite of the environments and the technologies that they have to work with. So some colleagues of mine, Susan Burnett and Charles Vincent, carried out some research a few years ago, which was sponsored by the Health Foundation. And what they did is they looked at the reliability of 4 clinical systems in 7 hospitals in the UK. So they looked at the availability of clinical information in outpatient clinics, prescribing for hospital inpatients, equipment availability in operating theatres, and systems for the insertion of IV lines. And essentially what they're asking the question, how reliable are these systems? And they defined reliability of as failure-free operation over time. And what they found is that between 13 to 19% of the time, there were reliability failures in these 4 different clinical systems. So, for example, a patient would turn up for outpatients and all the clinical information that was required to support that outpatient appointment wasn't available. Or some of the information on the prescription wasn't on the prescribing chart, etc. So this quote, I think, typifies my point that in healthcare, we design unreliable systems and processes, and then frontline staff work around them, they make do, and we make safe patient care happen in spite of the system. So when we're thinking about embedding human factors thinking in IT and digital technology design, we really need to think about that in terms of the need for broader cultural change. That actually this culture of tolerating bad system design is our goal should be to eradicate that and move away from it. Now, what you will hear from later is some wonderful, wonderful examples from pioneering trusts who have taken human factors approaches and thinking and applied it in the design process. And what they are doing is absolutely wonderful work, which is 1,000,000 miles away from what we've traditionally done in the NHS in terms of IT design. And I would say that the way we've designed and introduced IT in the NHS is pretty much akin to the design of supermarket self-service checkouts. So we've got this supermarket self-service checkout culture of design for our IT systems. And many of you will have been going home from work, you'll have popped into the supermarket hoping to get some groceries and be in and out in 5 to 10 minutes. Gone to the supermarket self-service checkout, you'll have your bag, your briefcase, your laptop, your shopping, you'll squeeze yourself into that tiny little space. You'll start scanning your items, you'll put your first item on the scanner, start scanning your second one, and then it will say, please place your item in the bagging area. And you look at it and you think, well, I just did. What are you talking about, you stupid machine? And so you have that moment of interacting with the technology and you think, why aren't you doing what I need you to do? And then you go to pull the bag down and you get 10 bags fall down. And then the system freezes completely because it doesn't understand that you want to buy something like ginger and you can't find it within any of the categories. So you look round and you try and find the poor assistant whose shift has been to oversee these badly designed machines, and they try and avoid making eye contact with you because they've suffered the stress and the wrath of 100 shoppers already that day, and they're thinking you're the next one. So what I'm saying is that the supermarket self-service checkout, the net effect of that poor design is that it creates stress, it creates irritation, it creates frustration. And quite interestingly, and this is a plea to everyone who uses one next time around, I had a conversation with a lady in one of the retail shops in this country who works in one of these shops, and she said, my husband always knows when I've been put on my shift to oversee the supermarket self-service checkout because I go home and I'm completely frazzled and stressed out. So the impact on the actual person who's overseeing it is similar to what it has on us as a shopper as well. Stress, irritation, frustration, completely fed up. So what we need to start thinking about is moving away from this culture of poor design, because when we don't embed human factors thinking in design of NHS IT systems and digital technologies, as Adrian and Alex were saying, we introduce patient safety risks. So we get situations, for example, with some of the IT systems that we've previously introduced where they create duplicate patient records when we've introduced an electronic health record, where suddenly the patient record can't be found, or we think we've done a VTE risk assessment, but then we can't find it on the system because it hasn't uploaded it and logged it. And a lot of the consequences and those outcomes are because we haven't really thought about how we design IT with human factors in mind, and we haven't done usability testing, and we tend to design NHS technologies without really understanding how people's brains are hardwired. So understanding how people's brains are hardwired is really, really important when we design IT, because we've got strengths and weaknesses in the way our brains work, and if the IT isn't designed and built to accommodate for those, then we will make errors, we create error traps which good healthcare professionals fall into that harm patients. So I'm just going to show you a video clip now. And the video clip shows a rotating mask. Just watch the video clip, and as the mask rotates to the hollow inside, just tell me what you see. See a face, don't you? Now, the reason that you see a face is because human beings are pattern matchers. So ever since you were a baby, you've been doing facial recognition. And in your memory, you have stored a pattern or a little schema which you retrieve when you're faced with this visual illusion. And when the mask rotates to the hollow inside, you over-apply the schema for facial recognition, because that's the one that you've applied 1 million times in your life. And that's the most frequently used schema. And so you misselect that one because you've used that so frequently in the past, it overrides you thinking and selecting the schema that you've got in your memory that represents the recognition of the hollow inside of a mask. So we over-apply schemas and patterns that we use frequently to interpret information from the environment. And when we're designing IT systems, and if we're thinking about, human factors standards for the design of IT systems, we need to understand how our brains are hardwired and the impact that this has on our interaction with those IT systems. So firstly, if we take pattern matching, and we're a prescriber working in a really fast-paced, high-stress, time-pressured environment like the emergency department, and we have an electronic prescribing system where there's one medication for which there are 2 different doses, or 2 medications where the first few letters are the same, and the prescribing template on the electronic prescribing system is not colour-coded, it doesn't differentiate between those 2 types of prescriptions, then we're highly likely to select the one that we use the most frequently if it looks like we think it should look. And that's because we're pattern matchers. We're also, as human beings, subject to what we call inattentional blindness. So, just to give you another example of the importance of thinking about human factors in IT design, I'm sure most of you will have seen a video where you're asked to watch 2 teams playing basketball on a stage, and you're told by the facilitator, please focus in and watch the team wearing the white t-shirts and count how many basketball passes they make during the video clip. And so you follow the instructions, and you're fixating on that team in the white t-shirts, and you're fixating on the counting task, and you miss a person in a gorilla suit walking across the stage. And that's because human beings only have so much attentional capacity, and we can get locked in to carrying out a particular task and miss other information in the environment. And we call that inattentional blindness, and Drew Vaughan Wolf very nicely illustrated this phenomenon in a study with radiologists. And what they did is they took that concept of the invisible gorilla and they mocked up some CT scans, and they said to the radiologists in their study, review these CT scans and look for evidence of cancer nodules on the CT scans. So they did. And they missed this image of a gorilla that had been etched into the left-hand lobe that was 48 times the size of an average cancer nodule. And that's because as human beings, you don't see what you're not expecting to see. And because the way we design tasks can sometimes make us very, very task-orientated. So another example where this has an impact on IT design, there are systems that we're starting to use now in the NHS where we introduce an IT system that allocates tasks, for example, across a district nursing team. And it's kind of, the IT is based on the principles of Uber. So you allocate district nurses based on their proximity. It's supposed to allocate based on their skill set, but the technology doesn't always accurately work that way. And what some of the district nursing teams who are trialling this software are finding is that the impact it's having on the user, the district nurses, is that they're allocated a wound dressing change for patient A, they're seeing a diabetic patient, patient B, and administering insulin, and they are going into the home and they are doing the task, and they are not seeing other problems with the patient. So sometimes the way IT impacts on performance is not considered when we introduce some of these solutions. And also the IT systems just sometimes can't accommodate for the challenges of London traffic, for the snow, for the work pressures, for the fact that sometimes you get delayed because you're trying to interact with carers in the home. And so the workload pressure builds up, and they're trying to keep up with the pace of the IT system, the task allocation process in the IT system. We also, as human beings, love to break the rules. So just another example of considering human factors thinking in design. So this shows Amilberti's model of systemic migration. And if there's a workaround to be introduced, human beings will introduce it. We're rule breakers. And so if I were to say to you, how many of you always stick to the 70-mile-an-hour speed limit while driving on the motorway in this country? Let's have a show of hands. Anyone does? Always drive at 70 mile an hour? We've got one shy person half putting their hand up there. Probably recently done a speed awareness course last week. Or owns like a Fiat Cinquecento, so the car will fall apart if you try and go above 70. So, but for most of us, what we do is we will do a mini risk assessment, and we will think, well, everyone else around us is pushing up to 80. It's a clear day. I want to keep up with the flow of traffic. So we'll drift outside what Amilberti calls the legal space into that illegal normal space where everyone drifts. And some of us will actually live in the illegal space, that, space where we routinely drive at 85 miles an hour plus. But most of us will just, through circumstances, drift outside the safe zone at some point. Now, sometimes IT design and the demands that we put on people overwhelms our ability as human beings, and that causes that drift. And there will not be one person in this room who I think does not recognise this issue. And it's not just about passwords for NHS IT, it's the number of passwords we now have to survive in an online digital world. So, we are told that to stay in that safe zone, we need passwords for our IT access that have small letters, big letters, special characters. But you've got online shopping accounts, you've got online banking, you've got your NHS IT systems. And there are so many passwords you have to remember that aren't easily memorable. So what do? We write them down. And so we've automatically drifted out of that safe space because the demands on us exceed our memory ability. Now, that's just 3 examples in terms of inattentional blindness, the issue with drifting away from safety, and the fact that we're pattern matchers, for you to consider when we're thinking about IT system design. And what we really need to be thinking about when we design NHS IT systems and digital technologies is, are we doing usability testing? And sometimes we think we are, but we're not doing usability testing in a true way because we're not thinking about all the different dimensions of usability when we introduce a new IT system. So, for example, learnability. Is how easy is it for users to use and to learn how to use the system? Efficiency, memorability. How easy is it once you come back to the system to reuse it after a period of time? What sort of errors do people make using the system? And satisfaction. And we also don't think sometimes about utility. Does the design do what the users need it to do? So some of the case studies you'll hear about later have really taken on board this idea of user testing. Because in any system design, there's often a mismatch between what the designer creates and what the user expects. And we need to make sure that those circles converge more by carrying out usability testing. And the other word of caution I would say about NHS sites that I work with who think they're doing usability testing is that sometimes they just don't understand this key principle. So when you do user testing, you need to make sure that your user testing thinks and considers about the least capable user in the most adverse conditions. And what I often see is NHS trusts introducing new IT technologies, and they will go and consult with the subject matter expert for blood transfusion or the subject matter expert for safeguarding, and they will get their perspective on how the system should be designed. Now, those people's views are important, don't get me wrong, but they are not the least capable user working in the most adverse conditions. So what I am talking about here is, for example, the locum GP who comes into work at the weekend in the urgent care centre. The A&E is falling over because it's over capacity, and they're asked to review a patient and work on an IT system in the ED department that's unfamiliar with them. Or the junior doctor prescribing in the ICU with a drug that they don't frequently use when there's no consultant presence on site. So this is what I mean about trying to factor in some thinking about the least capable user. And when we do usability testing, their input is the most important to get. So I just want to finish off talking about solution strength and design. So in 2012, the GMC published a study where they looked at prescribing errors, the prevalence and causes of prescribing errors in GP practices. And they identified that around 1 in 20 prescriptions has a prescribing error. And in terms of the causes they identified things like prescribing training, time pressure, distractions, lack of systems for ensuring blood tests, and also how we use GP prescribing systems and computer systems. And the solutions that they put forward, the recommendations that they put forward, very much were typical of what we do in healthcare. So we'll give the GPs more training on safe prescribing. We'll do more audits of whether there's been appropriate prescribing. And we'll tell people to use the computer systems more effectively and remind them about how to use the systems more effectively. Now, when human factors experts think about solutions and recommendations, we differentiate between person-centred solutions, which are generally the least effective type, and system-focused solutions. So, going back to that GMC practice study, what we have is more training, more audits, reminders to use the system safely. And the weakest, the least effective type of solutions are more education and training, writing another rule, writing another policy, reminding someone to practice safely, introducing a checklist to add to the millions of checklists we already have to use, which actually in the NHS now has reached a point where we just drive tick box behaviour, and introducing another check. And we think if there's an extra check, we'll make the world a safer place. And any of you who work with the WHO surgical safety checklist and have gone through that painful experience in your own organisation where every time there's an incident, someone says, well, we'll add another check in, and it becomes less and less usable. This is what I'm talking about here. So sometimes the kind of solutions that we put forward really don't embrace human factors thinking. So we don't think about how we design enforcing functions. We don't think about how we design, for example, electronic prescribing systems for GPs, where the automation and computerization that they're using supports them to do the job safely, that prescribing task safely. And we don't think about simplification and standardization as a solution. And what the work of a lot of the GDE sites that you'll hear about later is doing, and what you'll hear from the guys from the States, is solutions that really are stronger types, because people are starting to move away from just more training, reminders, tell people to practice safely, let's do another audit. So the one phrase I use there, which you may be unfamiliar with, is one of the strongest types of solutions is designing in a forcing function. And when we design in a forcing function, we design the IT in such a way that it forces us into being consciously attentive to the task. So it shapes your behaviour to make sure that you actually are not just working on autopilot. So the most common everyday example cited of this is a few years ago, the banks in this country realised that they had a problem in that people were going to the cash points, they were putting their debit card in the wall, they were getting their cash and then leaving their debit card in the wall. And that's because we've achieved our primary goal. We've got our money. Human beings, once we've achieved our primary goal, when we're carrying out a task sequence, we will drift off onto the next task on our to-do list. So now they've redesigned the cash point machine, so you have to pull out your debit card before your cash gets released, and that's what we mean by a forcing function. So just to wrap up, what I would say is that you're going to hear some wonderfully exciting, groundbreaking, pioneering case studies of human factors thinking in design today. I've come here to learn, and I think we're all going to go away understanding that some of the people who are speaking after me have really started on that journey of cultural change, where they're moving away from a culture of tolerating unreliable systems to one where we design with the end user in mind, and where we design with the understanding that it's not just about the IT system, it's about how the IT system fits and aligns with that complex socio-technical world that we work in. For example, a busy, fast-paced emergency department. And just to leave you with that message that we know from other industries that applying human factors, methods and approaches really does help us create safe design. So I'll stop talking there. Thank you for listening. I hope you've enjoyed it.